Thank you very much, Miro. It was excellent. I wanted to add one comment on the COVID question that you raised. We fully agree with you about this being a persistent issue for our bispecific patients, and indeed for some of our CAR Ts as well. We've actually had some real challenges with severe COVID infections that have persisted. I think persistence has been our biggest challenge, that cycle thresholds remain low and patients seem to have tenacious virus that it's difficult for them to shake, even in the setting of their disease being under quite good control. I'm just interested in what other people's experience has been, because we've been surprised by this. We've now several bispecific patients, and we've got a series of CAR T patients who've actually had the problem of persistent and life-threatening COVID.
Yeah, I can completely confirm this. We have patients that have been positive for COVID for weeks in spite of treatment. So this is an issue that they seem not to be able to clear the virus infection. And each time, and then it was a big discussion, when can we actually restart? But we waited in some of these patients really weeks to months before we restarted, until the patient finally then got COVID negative. And we're also careful about other respiratory tract virus infections. So also patients that have RSV or metapneumonia virus infection. So we would really stopped giving these patients or CAR T cells or bispecific, and really wait until the patient has cleared the infection, and then start the T cell engaging therapy.
Thank you, Meral, for this comprehensive overview. Just 2 comments. When you look at the Teclistamab study, and when you look at the data that were presented, you see a decline in the rate of infections. But when you normalize it for the number of patients which are still on study, you then find out that there's no decline or no decrease, contrary to our expectations with continued therapy. So that is something which we probably need to keep in mind. And when it comes to the IVIG, completely support what you have presented. Ideally, the donors of immunoglobulin should be vaccinated against the most prevalent agents in order to have an optimal product of IV or subcutaneous immunoglobulin for treatment of our patients. But that is probably unrealistic, but we still can talk about it. Yeah.
Yeah, Heinz, I think you point out very well. First of all, the first question, according to the decline in infections, you always are careful readers of data. But in daily practice, what I have seen is all the side effects that we experience, including the dyskinesia, the nail changes and things like that. These are usually maximum in the beginning, and then there is a kind of an adaptation. I think it's because of the intervals that we are changing. The escalation of the dosing has an impact. And on the other hand, the second issue you raised about the IV immunoglobulin and the immune protection potential of the IV immunoglobulin, this is an observation. We see a CRP increase in our patients, and sometimes it's hard to differentiate CRS versus the infection. And when I administer IV immunoglobulin, I see a decline in CRP. And this is a subclinic infectious or any microorganism that's causing the activation. And the IVIG immediately has an impact on it. This is a non-specific approach, but it's an observation.
And Muriel, are you referring to COVID or any infection?
Oh, any. I refer to any. I think I understood Heinz wanted to emphasize on the COVID immune responsiveness, but it's also valid for the others as well, because most of the infections that we are facing are latent infections, and we should all be immune to that. I have seen very strange infections such as Campylobacter jejuni, which is a rare observation for us in routine, but it happened in a patient who was in a clinical trial on teclistamab, maintenance therapy.
Meral, can I ask you a question, and maybe, well, the other members of the panel can also maybe reply. In clinical practice, are you doing some modifications according to the label for the use of the bispecific monoclonal antibodies in order to try to reduce, especially the infection rate, in order to make these treatments more convenient? And because we have experience with some patients that have to be off the treatment for several months, basically because infections, and the response was maintained in most of them. And in addition, this will facilitate a lot the sequencing for all these novel immunotherapeutic approaches.
Yes, of course. The only thing out of the clinical trial was Elrana, compassionate use, and that was strictly according to the protocol because it's a compassionate use. And the others are all clinical trials, so they are according to the trial design.
No, I think this is that's I think a very important question, and we had a lot of discussions about this in Germany already. And I think they're good data that if we give a bispecific antibody, teclistamab and elranatamab every week, that this leads to T-cell exhaustion. And Meral, you have nicely shown the data about the reduced infection rate when we expand the treatment-free interval from 1 to 2 weeks. We are currently even using teclistamab every 4 weeks to reduce the T-cell exhaustion and reduce the viral and infectious complications, especially in patients who have seen severe infection. We have several patients where we just couldn't give it weekly because of a lot of infectious complications. And after really achieving a complete remission, we then reduced the frequency of dosing to every 4 weeks. And we just saw that this is reducing dramatically infectious complications, and also looking at some T-cell exhaustion markers, that it also has a beneficial effect on the maintenance of T-cell function.
Yeah.
I agree with this, but I'd like to understand that what's the criteria response, and after how many cycles? For example, one patient after 3 cycles in VGPR, for example, or one patient with a CR after 3 cycles. My question is, sorry,
Vania, that's a perfect question. And I think this is definitely something we have to look into. I just looking at the different trials, it takes about a month until the patient shows a good response, and most of the patients have a complete response with a bispecific already after 2 or 3 months. So probably that would be the time frame when one potentially could start extending the treatment-free interval, I would guess, but maybe others have different opinions.
Yeah, it's an extremely good question, Vania, and I really am interested in this construct about frequency, Hermann, because I think the one thing that sets the bispecifics apart, and for that matter CAR-T, from other agents, is this CRS signal. And just to focus on COVID, I think that is the source of the issue, the endotheliitis, because that's the endothelial reservoir that the virus leverages, and probably why we see tenacity from the virus in these patients. And so any strategy that can reduce CRS, reduce endothelial toxicity from the immunotherapeutics, I think could be thought of in the infection setting as potentially helpful, because I really do suspect that is the kind of Achilles heel. And the reason I can say that with any kind of construct is because when we did our mezigdomide study, which Marie-V was part of, we saw 0 COVID mortality, 0, at the same time as the team were enrolling to the teclistamab studies, where the mortality from COVID-19 was very real. So the argument that it was just COVID and no one knew how to manage it, I don't think bears up, because in exactly that time period, using mezigdomide dex, which after all isn't exactly without its immunosuppression, we had COVID infection, but we didn't have COVID mortality. And I wonder if the endotheliitis is the Achilles heel.
On the
Okay.
And I just want to touch upon the efficacy issue for bispecifics. In another word, when you move from once weekly to every 2 weeks, for instance, for elranatamab, and in that setting, I have seen 2 cases who remained in CR in the marrow, but with extramedullary disease appearance. So that we know that in the extramedullary tissue, the penetrance of the immunotherapy is not ideal, but it coincided with the change in the interval for 2 cases. That's another observation.